El doctor Matthew Hamill es irlandés, pero se formó en Inglaterra, Bristol, Oxford, Cambridge, después pasó por Uganda y Gambia y finalmente terminó en Estados Unidos, en la Johns Hopkins, en Baltimore, después de pasar por Harvard. Es el jefe de las ITS para el Departamento de Salud de Baltimore y le hemos pedido que nos haga una charla sobre las incertidumbres o las dudas sobre el manejo de la sífilis. Thank you for being here, and the floor is yours.
Thank you for the kind invitation. I appreciate the opportunity to spend the next 20 minutes or so sharing some of my 25-year plus experiences in managing patients with syphilis. Some of the difficulties that we face, I will try and go over and provide a little bit of clarity around that. Here are my disclosures, and I wanted to acknowledge and thank my friend and colleague, Dr. Khalil Ghanem at Johns Hopkins, for sharing these slides. So what I would like to discuss is some of the clinical manifestations and management of syphilis and its complication in adults. In order to discuss all of the clinical manifestations, it would take 3 days at least. So I will just pick out a few choice examples. I'd like to review the indications for lumbar puncture and CSF examination. And finally, to describe the approach to managing non-treponemal titers that do not respond appropriately after treatment. So we'll start with a case, and I will frame the rest of this discussion around this particular case. It's a 38-year-old cisgender woman with a history of well-controlled HIV on BIC-TAF and FTC. Her last CD4 count was 875, and her viral load was undetectable at less than 20 copies per ml. She presents with a 2-week history of rash, fevers, chills, and a new onset headache. She has mild photophobia in both eyes, and she has discomfort in her right eye, and this is associated with vision loss. Her HIV was diagnosed 6 years earlier, and she has been very well controlled on her current antiretroviral therapy without complications. She has no history of opportunistic infections. She had a new male partner in the last 2 months and used condoms intermittently. So on examination, she's awake, she's alert, she's sitting in a room with the lights off, but she has no evidence of meningism. And on eye examination, she has evidence of a panuveitis. The rash is shown in the picture below, and there were no other neurological findings, and the rest of her examination was normal. Her laboratory tests reveal abnormal liver function tests, and they're notable for an alkaline phosphatase that's raised at a level of 780. Her screening treponemal test for syphilis was positive, and the RPR is likewise positive with a titer of 1:64. So here we have at least 2 diagnoses: secondary syphilis, syphilitic hepatitis, which I'll come on to, and then she likely has both early neurological syphilis with a headache and early ocular syphilis with the visual symptoms and the findings on eye exam. So I just want to briefly revise the natural history of syphilis infection. So sexual transmission only occurs in the early stages. It's estimated that after a single exposure, the risk of infection is about 40%. The index patient is more contagious during primary and secondary syphilis and less so in the early latent phase. Vertical transmission can occur at any stage of syphilis. It's much more likely when the pregnant person has early syphilis, but it can occur at any stage. And it's estimated that between 2 and 7% of people with syphilis will go on to develop CNS complications. On the right-hand side, you can see a very nice graphic that was published in the New England Journal of Medicine review paper in 2020 that's a very useful way of thinking about staging syphilis. And you can see that it's estimated that 40% of people will have evidence of CNS invasion even before the onset of a primary lesion. Of those, about 10% will develop early neurosyphilis, a third will be asymptomatic, the others will have symptomatic disease, including meningeal and meningivascular syphilis, and also early ocular and otic syphilis. Then, as you know, most people with syphilis, if it's untreated, will go on to develop latency that will last lifelong. but approximately 30% will go on to develop tertiary syphilis, and that can include late neurological syphilis and late ocular and otic syphilis. I mentioned this patient's abnormal liver function tests. In the pre-antibiotic era, late syphilis complications involving the liver were relatively common, and fibrosis and gummer and hepalobotum were well documented in the pre-antibiotic era. Syphilitic hepatitis, such as demonstrated in the case that we just looked at, is seen in the setting of secondary syphilis. It's associated with a rash, and it's associated with anorectal lesions. The histology can go from very mild inflammation through to severe inflammation with diffuse necrosis. It's estimated that approximately 40% of people with secondary syphilis will have abnormal liver function tests, but the vast majority of these are asymptomatic. So our patient has evidence of ocular syphilis, but what I want to do here is just to revise the otic and ocular manifestations of syphilis. I'll start with otic syphilis, and I think this is the most difficult stage of syphilis to diagnose. The clinical manifestations involve cochlear vestibular dysfunction and evidence of syphilis infection serologically without a reliable alternative diagnosis. And about half of people with otic syphilis will have bilateral involvement. The symptoms include hearing loss, vertigo, and tinnitus. The diagnosis of otic syphilis is presumptive. A CSF examination is not recommended, at least in the CDC guidelines in the United States, and that's because more than 40%, and in some case series, 90% of people with otic syphilis will have completely normal CSF. The therapy is with intravenous penicillin, and the prognosis is very variable. Less than 25% will experience improvements in their hearing, but about 80% will experience improvements in tinnitus and vertigo. So for otic syphilis, it's really important to ask your patients, do you have any changes in your hearing, any ringing in your ears? Because they're often quite subtle symptoms, and unless the provider or the clinician asks the patient, they may not volunteer those symptoms. With ocular syphilis, any part of the eye from the front all the way through to the back can be affected by syphilis, and this can happen at any stage, from primary all the way through to tertiary. The symptoms are likewise very diverse and can include redness, pain, floaters, and loss of visual acuity. Again, with ocular syphilis, the diagnosis is presumptive. Because CSF examination will be normal in up to 40% of cases, it is not recommended it's not recommended as part of the diagnostic workup for ocular syphilis. And again, the treatment is with intravenous penicillin. It's very important for both of these conditions that we manage them in infectious diseases along with our colleagues in ophthalmology and ear, nose, and throat specialists so that the patients can get the best care by a combination of inputs from different specialists. So the question that I'm asked very frequently is, does this patient need a CSF examination? Do they need a lumbar puncture? For people with syphilis who have neurological signs and symptoms, they certainly need a CSF examination. Patients who are diagnosed with tertiary syphilis likewise should be offered a CSF examination. And we can consider CSF exam in those who are asymptomatic, but whose serological titers increase after stage-appropriate treatment in the absence of reinfection, and I'll come on to this in a bit more detail shortly. And we can also consider in asymptomatic individuals whose titers fail to decline fourfold in the absence of reinfection. And this is particularly true in people with latent syphilis who have a high titer at baseline of 1 to 64 or above. There are no data to support routine CSF examination in asymptomatic people with HIV. So a few take-home points around neurological, ocular, and otic syphilis. A normal CSF examination rules out neurosyphilis, but it does not rule out ocular or otic syphilis. A patient who only has otic or ocular signs and symptoms does not need a CSF examination. What they need is immediate clinical evaluation by the appropriate expert, and if the clinical picture is compatible, then they should start antibiotic therapy straight away. A patient such as the one that I presented who has both neurological, so a headache, and ocular or otic signs or symptoms should also undergo a CSF exam. While it might not impact the treatment that they receive, it may have important diagnostic considerations. There may be other things that are underlying this patient's symptom profile, and it's important not to delay diagnosis of alternative pathologies. So how do we diagnose neurosyphilis? As with most things related to syphilis, it's not that straightforward. There's no single test that we can use in every clinical context that will reliably diagnose neurosyphilis. So we use a combination of different strategies. We look for serological evidence of syphilis, but I would note that in patients with tertiary neurosyphilis, they may have non-reactive RPR or VDRL titers. A reactive CSF VDRL is very helpful. Its sensitivity is poor. It's only about 50%, but it's highly specific in the absence of any blood contamination. In the United States, we only use VDRL. We don't use the CSF RPR because it's less sensitive in some studies compared with a VDRL. Looking at CSF treponemal antibodies, these are highly sensitive but have lower specificity, so they have a high negative predictive value. CSF white cell count is the most sensitive parameter. If it's greater than 5 white blood cells per ml, it's suggestive or supportive of a diagnosis of syphilis. In people living with HIV who are not taking antiretroviral therapy, then if you increase the threshold to 20 white cells per ml, then the specificity of a CSF pleocytosis increases. And then finally, an elevated CSF protein, which in truth, I very rarely use as a guide to making a diagnosis of neurosyphilis, unless it's extremely raised. So this patient, she undergoes a CSF examination. She has 22 white cells, 98% of which are lymphocytes. Her protein is raised, and her CSF VDRL is non-reactive. She starts on intravenous penicillin with an intended duration of 10 days of treatment. And the ophthalmologist who's providing care for her as well requests the use of oral prednisolone in order to treat her uveitis. So our next conundrum, our next question is, should steroids be used in the treatment of ocular or otic syphilis? There are really no data to support this decision, and when I worked in the UK, then it was something that we used quite frequently. The CDC STI treatment guidelines do not recommend the concomitant use of corticosteroids for ocular or otic syphilis. If steroids are used, then occasionally when they're stopped, the symptoms may become worse again. One option is to follow the patient clinically, the other is to restart the steroids and provide an extended duration of treatment. So this patient has completed her 10 days of intravenous penicillin. And the question that you're asked is, should you use additional doses of benzathine penicillin G after she's completed her intravenous penicillin? So there's a question, a long-standing question and a debate about the need for additional doses of intramuscular penicillin after the completion of the 10 to 14 days of intravenous treatment. The CDC guidelines say the durations of the recommended regimens for neurosyphilis are shorter than the duration of the regimen used to treat latent syphilis. Therefore, benzyl penicillin G, 2.4 million units intramuscularly once a week for 1 to 3 weeks can be considered after completion of these neurosyphilis treatment regimens to provide a comparable total duration of therapy. So that's a really long-winded way of saying that the duration of treatment for neurological syphilis is shorter than the duration of treatment that's given typically for latent syphilis. And the concern is that the duration of the treatment for neurosyphilis is not long enough. However, this recommendation is not based on any clinical or experimental data, but rather it's been in the guidelines for decades and it's based on expert opinion. So in this era where we're seeing shortages of injectable BPG, I avoid any additional doses of injectable penicillin when treating for late neuroocular or otic syphilis. So the next question is, does this patient need a CSF examination after completion of treatment? And here, European and American guidelines differ. In the US, we say that there is no need for further lumbar puncture after the diagnosis and treatment of neurosyphilis, both in people who are HIV uninfected and in people living with HIV who are on antiretroviral therapy, if they clinically improve and if their serological titers respond appropriately. And there are two studies here, which I won't go through in detail, but essentially they say that the normalization of non-treponemal titers in the blood predicts the resolution of CSF abnormalities in greater than 90% of patients. So this patient, she's received her treatment, but over the course of 2 years, her RPR titer only declines twofold, from 1 to 64 down to 1 to 32. So what should we do here? Just to quickly revise syphilis serological tests, and particularly the non-treponemal tests, you'll be aware that the RPR or the VDRL is very helpful both in diagnosing syphilis, but also in monitoring response to treatment and to provide evidence of relapse or reinfection. So the RPR titer goes up and then it falls following treatment. And we expect to see at least a fourfold decline in RPR titer, and that's how we determine serological success. The treponemal tests are not helpful for managing syphilis follow-up. And the reason for that is that these tests, once they become positive, they stay positive lifelong, so you can't use them in order to look for response to treatment or to look for evidence of relapse or reinfection. So how should we manage RPR titers that don't respond appropriately? And I'm guessing that every person in this room who's managed somebody who has had a syphilis diagnosis has, at one time in their career, been struggled with how to interpret the RPR or VDRL after completion of treatment. So this is a quote from my friend and colleague Khalil Ghanem, who says, when you get frustrated with RPR titers, you just have to remember one fact. And that fact is 1906. And the reason that I say that is that we've been using essentially the same non-treponemal test to diagnose and monitor response to treatment for almost 120 years. And the reason that I share that with you is just we have to give ourselves a bit of a break. Sometimes we're relying on using a technology that's almost 120 years old to make interpretations of complicated clinical decisions. Can you imagine that it's the year 2100, we're sitting at this conference, and we were still using a Western blot as the only way that we diagnosed HIV and managed response to treatment? We have come so far in the science of HIV, and I've been so impressed with the presentations here at this conference, but with syphilis, we're still using a test that's almost 120 years old. So I say that to you, not to so that you become disheartened, but just to put into context the fact that we're using not a very good test in order to make these treatment decisions. So to try and provide a bit of context here, I'm just going to give an overview of how I think about serological non-response. And this means that the person, like the patient that I've just presented, her RPR titers didn't fall fourfold over the course of follow-up. So the first question to ask is, are there any neurological, ocular, or otic signs or symptoms? If yes, then this person should be managed appropriately. If no, did you wait for long enough for the titers to decline? And in the United States, any person living with HIV, the CDC recommend that we wait for 24 months, for 2 years, before we adjudicate whether their RPR titer has declined sufficiently. So if you didn't wait for long enough, relax, repeat the test, and keep following the patient. Did the patient get reinfected, or is the patient pregnant? If yes, then please retreat. If the patient there's no evidence to suggest that the patient could have been reinfected, and if the baseline titer was greater than or equal to 1/64, particularly in latent disease, then you can consider a CSF examination in this context. If the titer is less than that, then just keep following the titers. Keep in contact with your patients. Ask them to let you know if they develop new signs or symptoms. But there's no need to panic. There's no need to use a test that's 120 years old in order to put the patient through unnecessary lumbar puncture, CSF examinations, and additional treatments that they might not benefit from. So there have been 5 observational studies that show no difference in intermediate-term outcomes between treatment or just watching and waiting to see what happens with the titers. But if you feel better for treating the patient, and if the patient feels better, then there's nothing to stop you from doing that. But I would implore you, please just do it once. Don't treat the patient over and over and over again, which is something that I see all of the time in my clinical practice. The next scenario is, and I'll finish here, is about serological failure. So this is in a person who has had a decline in titer, but then their titer has increased again without any evidence of reinfection, so without any new exposures. There's a huge social desirability bias. Patients come to us, they want to provide us with the information that they think that we want to hear, and often that they will minimize or deny a sexual exposure, when in fact, if they told us that, it makes our lives and their lives much easier because we can then just offer them retreatment. So I say that just to encourage all of us to allow patients to give their sexual history in a very open-minded, non-judgmental way. So again, in this context, we ask, are there neurological, ocular, or otic signs and symptoms? If yes, we manage it accordingly. If no, did we repeat the titer at least 2 weeks later? If you didn't, then please repeat the titer after a minimum of 2 weeks and see whether it remains elevated. Are the titers still elevated? If no, fantastic, great. You can relax and everyone can go home and enjoy the rest of their day. However, if the titers are still elevated, then at that point, you can consider a CSF examination. If the CSF examination is normal, you can consider retreatment, but again, only retreat once. There are no data comparing outcomes for patients who undergo a CSF examination versus those who have empiric retreatment with 3 doses of BPG without a CSF exam. So really what I'm saying is that we have, because of the absence of data, we have permission, I believe, to do either of those things, to either do a CSF exam and treat accordingly, or to offer patients retreatment without a CSF exam. So this is my final slide. I mean, this has been a real run through some of the dilemmas that I face every week as a syphilis doctor. But I think in some ways the fun is just about to begin, because in the era of doxycycline post-exposure prophylaxis, and we had some great data this morning, we just don't know what doxy-PEP is going to do with syphilis. We don't know how it's going to hinder us in interpreting non-treponemal tests. So I think we have a ton to learn. We have so much to learn about how we manage syphilis in the era of doxycycline PEP and what it does to the trajectory of the non-treponemal titers. And one thing that I'm slightly concerned about is that we might miss early neurological syphilis in people who are taking doxy-PEP, because their presentations will be altered by the fact that they have an antibiotic on board that has anti-treponemal activity, but not enough dose in order to treat them sufficiently for neurological disease. So I'll end there. Thank you so much for your time and attention.
Thanks for this excellent presentation. We have 5 minutes for questions. We have José María Libra here.
Matthew, my congrats for your excellent presentation and review. The question, what about the recommendation on performing a lumbar puncture in people with low CD4 cell counts, an HIV infection? The recommendation was like in people with secondary syphilis for syphilis of unknown duration, but unknown neurologic symptoms, performing a lumbar puncture if they had less than 350 or 200 CD4 cells. The rationale was they could have neurosyphilis, and it had an impact on the treatment from benzathine penicillin to intravenous penicillin. What's your opinion?
Yeah, thank you for the question. So if I understood it correctly, it's what do we do? Is there still a recommendation to do a lumbar puncture in people living with HIV with a CD4 less than 350, particularly in those who have a high titer of 1 to 32 or above? I mean, that certainly was practiced for many years, and some clinicians still do that. I think that really there's a paucity of evidence of benefit in those scenarios. And I think particularly if the patient's on antiretroviral therapy, then certainly in my practice, if someone is asymptomatic and they have a low CD4 count of less than 350, but if they're taking antiretroviral therapy and they don't have any worrying signs or symptoms, I don't offer lumbar puncture in that scenario. Some people do that, and the CDC STI treatment guidelines has some flexibility within the language that will use that, that will allow that. But I think, at least in the US where I work, in Baltimore, we've really moved away from doing CSF examinations in patients without symptoms.
Jose Miró, brilliant and very practical talk. Congratulations. Two questions. The first one is, do you expect that in the future, because of the PEP doxycycline use, we could detect syphilis-resistant strains to I wonder if you can hypothesize on this issue. This is the first question. And the second, you believe in penicillin G is the drug of choice for treating neurosyphilis. Do you believe that the triaxone or for penicillin allergic patients, doxycycline or even an linezolid could be alternative? What your opinion on these two issues?
Yeah, I'll start with the first one because I can answer that with a little bit of confidence. So I think that there are data to support the use of ceftriaxone to treat neurosyphilis. And those data are good, and I think that they are robust. So certainly that's something that I would consider in a patient who is unable to receive penicillin, but is able to safely receive a third-generation cephalosporin. So I think I think the data there are supportive of that decision. High-dose doxycycline is something that I've been interested in for many years as a treatment modality for neurological syphilis. There are some data that are not great, that do support the use of high-dose doxycycline, so 200 milligrams twice daily to treat neurological disease. There is a planned randomized control trial coming up that should definitively answer that question. So it's not something that I would use when I work in the United States to treat neurological syphilis. When I worked in the UK, then it was something that I did use. Linezolid, I think the jury is out because of the disappointing results from the clinical trial that was performed. In terms of doxycycline resistance, to answer your first question, I think it's such a great question, and the short answer is that we don't know. You know, we now have a cell culture model where we can grow Treponema pallidum, and we can start to do experiments to looking at antimicrobial susceptibility testing, but that's only available in a couple of research laboratories. So I think the question, could T. pallidum develop resistance to doxycycline because it's being exposed in sublethal doses? Then the answer is probably yes, but I think we have to wait and see. We certainly see very widespread resistance to macrolides in T. pallidum, so there is some precedent to worrying. There is some precedent, and we should keep an open mind about that.
Última pregunta, Luis.
Hi, thank you. Luis Buzón from, of course, Spain. Thank you so much for such a useful talk. I have a very straight question. In my daily practice, it's quite common that gynecologists give us a ring asking for a migrant person living with HIV, most commonly coming from South America, and she presents asymptomatic with a negative RPR and a positive treponemal test. So as long as the RPR test can become negative, either with or without treatment, what is the most reasonable approach to this situation? Should we treat all, in this case, migrants coming from South America or Spanish, it doesn't matter, with negative RPRs, or should we assume they became cured while taking amoxicillin or amoxicillin clavulanate or doxycycline, or what is the best approach for this common situation? Thank you.
I'm always nervous when people say they have a straightforward question to ask me, because the answers are usually complicated. So I thank you for your question, and it's something that that I see in my practice as well. I mean, what I like to do before I make any treatment decisions is to be sure that that person has sufficient serological diagnosis of syphilis. So if they have a positive treponemal screening test and a negative RPR, then they should have a second and different treponemal test to adjudicate those two results. So that's the first thing. Does this person have serological evidence of syphilis? And if they do, even if the RPR is non-reactive, even if they may have been exposed to an endemic treponeme that will give a false positive serological test, I will always offer that person treatment, because I want to make sure that those downstream complications of tertiary syphilis are avoided, and in people who may become pregnant, to avoid the possibility of mother-to-child transmission of syphilis.
We have to stop here, and we'll go to the next speaker. Thank you very much for your talk. Vamos con el último.